I have a clinical background. I'm a physiotherapist, and it's just been 18 months since I've been in my project management role, stepping out of my clinical role. But that is another story. But if you'd like to know more about that, do speak to me over coffee or lunch. So I'm delighted to have been invited here today by the Lean Healthcare Academy to tell you about the Ashford and St Peter's Releasing Time to Care project, a trust-wide approach to releasing time to care. So just to tell you a little bit about my hospital, we're a medium-sized district general hospital with approximately 500 beds over 2 sites, and we employ around 3,000 staff. We're the largest provider of acute services in Surrey, serving a population of 380,000. So as I said, this was a trust-wide project involving 5 surgical wards, 9 medical wards, 2 orthopaedic, 2 maternity, 2 paediatric, and 3 rehab wards over the 2 sites. I have a core project team made up of 6, and then a wider team of about 40 representatives across the trust. So just to set the scene for this project and just to bring out sort of 3 themes to give it in the wider context. So quality and safety. As you'll be aware, Robert Francis in his mid-status report speaks a lot about patient safety and states that it should be at the top of the healthcare agenda. Releasing Time to Care is a programme that directly impacts patient safety, and hopefully you'll see some evidence of this in the work that I'm about to describe to you. Improvement culture. Again, as I'm sure you'll appreciate only too well, cultural changes are hard to achieve. And developing a culture of continuous improvement within our organisations would seem to be the key to resolving many of the issues and challenges that we face in the NHS today. So again, I hope to show you how this project has gone a little way towards this sort of culture shift. Oh, sorry, I've forgotten to click the buttons. There we are. And then making use of a national improvement programme. The Productive Ward is a programme designed with quality improvement at its centre. And importantly, it's about empowering clinical staff to take ownership of their improvements and enabling them to demonstrate good leadership as they follow the Releasing Time to Care processes. So this ward level ownership has been central to the success of this project, and again, I hope that you'll really see that coming out. So bringing it back down to Ashford and St Peter's, this is a quote from David Fillingham from his book Lean Healthcare, and he importantly says that you need to make lean your own in order for it to become embedded in the organisation's culture. And this is certainly one of the things that we've done with the project. So although we've used the Productive Ward methodologies, we have really tried to make it our own. We've taken this unique trust-wide approach. And this was really important as we have run Productive Ward a couple of times before within our hospitals. In fact, we were one of the early implementer sites back in 2007, but we've never really managed to fully complete the programme. So this time it really had to be different. This time we've had a dedicated project manager in the form of me, which again has really helped, and working with named representatives on every ward as well. We've been able to offer an incentive scheme. So I managed to get funding agreed from our chief executive to run this, and I'll give you some more details about that in a moment. Now, I don't know how many of you are familiar with Productive Ward, but this is the Productive House down here. And previously when we've run, click the wrong button, wanted the little light. Previously when we've run it, we've focused on these 3 foundation modules: knowing how well we're doing, well-organised ward, and patient status at a glance. So wards have done really well at completing those. So this time, we've really decided to focus on the 8 process modules, which are the ones at the top of the house there. And I'll give you some examples of those as we go on. Linking with other projects has also been vital. Ward staff get asked to do so many different projects, and they get really, really tired of being asked to do something else on top of yet another thing. So we've really tried to sort of link up and make sure that they're not duplicating their work. So here are just a few examples of the things that we've linked with. So you can see they're ready to go. This is a project focusing on timely discharge of patients. So we fed back findings from our admissions and discharge module to the Ready to Go team. VTE prevention, we focused on this for our nursing procedures module as it tied in with some other VTE work going on across the trust. Real Time is an IT solution that covers the patient status at a glance foundation module. And Living Our Values, this is a programme promoting our 4 trust values. And this is an example. This is our Living Our Values boards, also covering the Knowing How Well We're Doing foundation module of Releasing Time to Care. So the board is split into 4 quarters which correspond with the 4 trust values. And you can see in the top left-hand corner there we have our productive house. Here's a bigger example for you. So this shows how well the ward is progressing with their modules. So it gives you the direct care time percentages before and after each module. We keep these updated on the ward boards. They're public-facing, so patients and relatives can see exactly the progress that we're making with Releasing Time to Care on the wards. And here's an example of the Well-Organised Ward Foundation module, which I say was covered pretty well in the previous runs of Productive Ward. So you can see that the clean utility rooms have been nicely racked out and labelled, and most of them still look like that. And the little trolleys as well were purchased by one ward to have their sort of key items actually in the bays rather than the nurses having to go backwards and forwards to get them. And that idea has been adopted across lots of wards as well. So I mentioned the incentive scheme. So executive approval and support was gained for this, which was no mean feat, but we did it. So each ward can access £75 per module that they complete. So there's 8 modules altogether, so that's a total of £600 over the project that they can access. We also have an £850 Dream Team Award for every module, so there are 8 of these awards up for grabs. And I keep a league table of the wards participating in the modules, so they get awarded points for their levels of engagement, for getting feedback back in a timely manner as we go on. So it's quite sort of transparent, and then we get the points, and then whoever's at the top of the table at the end of the module gets awarded the Dream Team Award. And this is it's created quite a sense of competition amongst the teams, and also a sense of camaraderie, particularly within medicine, who seem to be doing very well at winning these awards. So they can spend the money's cumulative, and they can spend the money on things that will help them implement or maintain the changes that they've identified through the Releasing Time to Care project. So just to give a few examples, some of them have bought new folders to put paperwork in. We've had filing cabinets, whiteboards to help them with their board meetings, and we've also got a new patient observation machine on trial at the moment, so hopefully that's going to be a really significant piece of equipment that somebody can buy with this money. Communications has also been key. We developed a detailed communications plan before the project started, detailing how and when key information about Releasing Time to Care would be communicated. We did need to give us some careful consideration about how we were going to communicate, particularly with ward teams, because they don't always access PCs. A, there's not enough of them on the ward, and B, they're just too busy. So emails and intranet was not necessarily going to be enough, so we just had to give some consideration to that. So the first thing we did was to give ourselves an identity, and you'll notice the heart up in the corner of my slides there. So this little heart has become well known across the trust now, and it's actually been adopted as our nursing and midwifery strategy logo as well. It's changed colour to gold, but they like the heart. So the heart is everywhere. People know that this blue heart with the Releasing Time to Care is what this project's about, and obviously our Dream Team logo as well. We also managed to get a nice sort of tagline from our chief nurse. She said that this project is about making more time for nurses to do what only nurses do. And that was really lovely, so I quickly wrote that down when she said it, and we've used that a lot on all our communications, just to keep people focused on what this project is about. I mentioned the internet. We do put out regular e-bulletins and use our intranet. We've got specific Releasing Time to Care pages on there, which gives all the information about the modules and the progress being made. The productive houses are up there, quite visual. They sort of scroll through the different wards. So we have got that communication, although as well the other things for the wards. So I produce a paper newsletter. We've had 4 of these newsletters so far. I've got some examples if you'd like to have a look at those a bit later. But that's been really good as well. So that goes out to all the wards. It's up again on public-facing boards. All the exec team get one. Just details the progress that we're making with the project as we go through. And in May, we held a Pride in Nursing and Midwifery Day. This is started out as an idea from me to have a nice afternoon tea for our Releasing Time to Care reps, just to celebrate the halfway mark of the project. It kind of expanded and expanded, and we ended up with a whole day sharing and showcasing nursing and midwifery achievements. But Releasing Time to Care was really central to that, and we did get some really good feedback after the event as well, suggesting that we'd given a real boost to staff morale. I've also done some walk-arounds with the chief nurse and with the chairman of the trust. Again, really good to go and visit the wards and ask them to explain what they're doing. Really nice for them to see that there's that executive support and buy-in on the project. So how did we actually do it, getting down to ward level? So again, those of you that are familiar with the productive ward would have seen this improvement cycle. I've christened this the hairdryer of change. So you probably, hopefully you can see why. So basically we've taken the wards around this cycle 8 times now as they're on their last module. So for the prepare stage, I prepare a detailed action plan for them which I take out to the ward teams. So that bit's done for them. It gives them all the tasks that they need to do and gives them timelines as to when they should be done. And again, critical points where I need activity follows and feedback to come back to me. Assessing, we've been using 1-hour activity follows, so really focusing our activity follows on the particular module that we're looking at. So again, this is part of making it our own, because I think the productive ward actually suggests a lot longer than 1 hour. So we felt that 1 hour was sufficient, so we've been doing that. So they do their 1-hour activity follow, they do some process mapping to map out their current process, they get feedback from staff and from patients. And then we move on to the diagnose and planning. So at this point, feedback comes back to me, which I review with my project team. We just have a look at the sort of issues that are coming up and the sort of ideas. And then we review it. And then 9 times out of 10, we go back to the wards and say, great, try out your plans. So that gets to the treat stage. So they carry out their changes to see what effect that's having. They allocate a time where they're going to do it, communicate to all their staff, put it into practice. And then we get to evaluate. So they repeat their activity follow again, repeat their staff and patient feedback, and any other measures that we've used as well. And then final feedback comes back to me and the project team about the changes that were implemented, the impact that they've had, and the overall experience for the module. And from there, we can collate all that information, and then we've been able to make some trust-wide recommendations as well from this feedback. We've taken 8 weeks to complete each module, so the process goes through. But as I say, they go through the same process for everyone. And again, I'm sure you'll see the similarity with the PDSA cycle. So Plan, Do, Study, Act is an NHS improvement cycle that has been commonly used. The really nice thing is that they've not even realised that they're going through this as we've been going through the modules. So it's been sort of improvement by stealth. But now we're coming to the end of this project, I'm making them aware of this, that do you realise this is what you've been doing? And you've done this nearly 8 times now, you've been round this cycle. So now really trying to let them know that they've got this framework, they can use it for other stuff. It doesn't have to be Releasing Time to Care. Any improvements that they'd like to try out on their wards, they've got the tool to do it now. So this is part of actually embedding the improvement methodology within the culture of the organisation, and I do believe it's started to happen. So I talked about the measurement. Again, for those of you that are not familiar, this is a 1-hour activity follow sheet, which looks a bit scary, and most people have been scared when I've presented them with this to start with. But essentially, they follow one of their colleagues around for an hour, and every minute they record the activity that they're doing. So they record their actual task, what they're actually doing, their intended task, what they should be doing, and they also log interruptions as well. So this is how we've been monitoring. And then when we've got the hour's worth of data, we can calculate a percentage direct care time. So this gives you the percentage of time that they've actually spent face-to-face with the patients. The only module that we didn't use this, and again part of making Lean Your Own, was our nursing procedures module, where I mentioned we were looking at VTE prevention. And we were really looking at the nurse's role in caring for patients and preventing VTE on the wards. So it wasn't appropriate to use the activity follow for that, so we developed a checklist that we used instead, which was, again, very successful in monitoring the process. So here's a nice example of some process mapping. This is one of the wards on the very first module, so I was really impressed with this. They mapped out their admissions process, and they actually identified that they could save 15 minutes just by organising their paperwork. So that's exactly what they did. They used their releasing time to care money. They bought new folders and put all their admissions paperwork in the folders. These are kept stocked up by the ward clerk, so whenever a patient arrives, the nurse can just grab the folder, go and sit with the patient and do the admission documentation. They don't have to do what they were doing before, which was running backwards and forwards to find bits of paper or having to print things out because they weren't available. And these were in fact our first dream team, Maple Ward. And this is our chief nurse here, Suzanne Rankin. Oops, sorry, I keep doing that. Where have they gone? There they are. So Suzanne is there. This was on one of our walkarounds. We presented them with their, they get a certificate to say that they've won the Dream Team Award, and they also get this banner to keep on their ward for the duration of the next module. So it's very visible to everybody that that's what they've done. So they developed their pre-admission folders. They actually increased their direct care time from 12 to 40%, which actually saved them 17 minutes in the hour, so better than their estimated 15. And this had an overall impact on patient experience and also improved the quality of their paperwork. So how are we doing? So that's one example. So I'm just going to share 3 further examples with you of the direct care time improvements and releasing time to care changes that we've been made. So just to start with our baseline values, what we did at the beginning of the project was we actually carried out a 4-hour general activity follow. So they did 4 hours worth of general ward activity to give us our baseline figures. And as you can see, there's quite a lot of variation in the direct care time values there. Our average was 46%, and we're aiming for at least a 10% increase at the end of the project, which is what's recommended by the Institute. Now, as you can see here, all our wards completed this baseline follow, which was fantastic. We're 23 wards. Again, we're a district general hospital, wards open and close. We're down to 21 wards at the moment, and who knows where we'll be in a few weeks when we do our repeat follows. But anyway, that's just the way it goes. So some of the wards as well, just to make a note here, some of the wards haven't completed the modules, and this was something I considered at the beginning of the project. Was it necessary for every ward to complete every module for the project to be a success? Well, I concluded that no. So long as we had a sort of core group of wards completing each module, we could draw learning from that which could be applied across the trust, and that's exactly what's happened. So, shift handovers. This module coincided with some changes to our shift patterns, and we thought it would be particularly helpful for the nurses to work through this to help them solve some of the problems they were having with a reduced overlap time between shifts. And interestingly, we had the greatest level of engagement with this module as well. So out of the shift handovers, we've come up with 3 releasing time to care handover principles. The first of which is that the nurse in charge should take the handover for the whole ward, and the other nurses should just get a detailed handover for their specific bays and rooms. So really making the handover specific. It should be by the bedside, so involve the patient in the handover as well. And what was happening was that the nurses were disappearing off into a room, sometimes for an hour at a time, all of the nursing staff. That's a long time for them to be away from their patients. So by the bedside was really important. And also making sure that the handover is concise and only the necessary information is conveyed, and using something like SBAR, situation, background, assessment and recommendation, to actually do that. Again, we found nurses have got handover sheets, and what they were doing was just reading out the information that was on there. Well, they can all read, they don't need to do that. So just being really specific about what they're giving. So these 3 principles have now been integrated into our monthly best care dashboard. So they're audited against regularly, which is really good. And again, goes some way to embedding these changes within the organisation. And we had a really nice comment from one of the nurses after doing the module, was that handover isn't delayed anymore, so I can go home on time. So here's the numbers from this. So our average direct care time before we completed the module was 23% and afterwards 42%, giving an increase of 19%, which is 11 minutes released in the hour for direct patient care. I also looked at the amount of time that was being spent on handover, which I could get from the activity follow sheets, and we did reduce that from an average of 36 minutes to 22 minutes. So that correlated with the change in direct care. Here are our Dream Team winners, Cedar Ward. They made huge improvements in their direct care time by actually adopting all 3 of those handover principles. And they saw, as a result of this, improved documentation, a reduction in drug errors, and their board round, more importantly, started on time so their nurses could go home on time. They made a dramatic increase in their direct care time from 3% to 50%. So that was 30 minutes more spent with the patients. They were one of the wards that were doing their handovers completely away from the patients. So moving to a handover by the bedside was a huge improvement for them. Meal times was the next one I'd like to share with you. This was the first module where we saw an idea start on one ward and really rapidly spread to other wards, and to the point where it was difficult for me to work out where it started, but I did find out in the end. So again, we came up with some recommendations about meal times. First of all, for patients to pre-order their menu choices. So about half an hour before the meal service is due, staff can go around with the menus and actually have a conversation with the patients about what they'd like to choose. This saves a lot of time and makes meals much more enjoyable for the patients, because they don't have that stressful moment where the meal's there and they've got to choose what they want. So really, really good to do that. That all staff should help with the meal service. Again, it seemed to have got lost that this was actually part of nursing care and caring for our patients, that actually everybody should be involved in meal service. So we recommend that they all don their green aprons and help with the meal service. And rescheduling of drug rounds as well. Again, a few wards had got their drug rounds directly coinciding with meal service, which A, meant that there weren't staff available to help with meals, and B, again, not a great patient experience when you've got your tablets coming at you and your meal coming at you all at the same time. So some of the wards did actually change their drug round times as well. And again, one member of staff, in fact it was this ward where the picture's taken from, commented that meal rounds are more relaxed and more organised. So a better experience for staff and for patients. So data on meals. So we started at an average direct care time of 72% beforehand, ended up at 91%. Another 19% increase, so another 11 minutes freed up for direct patient care. And as you can see, that this module did prove very successful, and the changes to practice have now been widely adopted across the trust. So here's our Dream Team, our short stay unit, and this was where the pre-ordering originated. So they developed this little form that they just fill out the choices for the patients. Then when the trolley arrives, the housekeeping assistant has the form, and somebody can just say, right, we'd like 3 lasagna please, 2 chicken, 1 vegetarian, and they can just dish it up, and then it goes to the patients really quickly. And then the staff are then free to go back and help patients that need assistance with feeding. So they increased their direct care time from 83 to 98%, giving them an extra 9 minutes to care for their patients. And finally, medicines module. This was one that we completed fairly recently. I've got the numbers first on this one. So you can see not so many wards participated in this one, but as I said, I decided this wasn't so important because we can still draw some learning that's applicable across the whole trust. I said this was a fairly recent one, so I have actually got some more follows coming back in now, which is good. So we started with an average of 66%, increased to 87%, which was a 21% increase, so 13 minutes released in the hour through the medicines module. I've just got some examples here of the sorts of changes that happened. So, hang on, got the wrong slide. We introduced these red aprons. Some of you may have seen them before. So it says, drug rounds in process, do not disturb. So the 2 wards that piloted this through the project actually both reduced their interruptions to nil. So I think one of them had 8 interruptions during the drug round, another one had 11. They both went down to 0 just by wearing these red aprons. And others are now adopting this. So we are going to roll this out across the trust, but we're aware that we need some very careful education around this for staff, for patients and relatives. So we've designed some banners which will quite clearly state that you shouldn't interrupt the person doing the drug round when they're wearing this red apron, but that there may be instances, if you think something is urgent, when actually it is okay to interrupt. So we're just making that very clear. But also we need to let staff know that it applies to them as well. When it says do not disturb, that applies to other members of staff. And also making sure that the person wearing the apron is empowered to say no. We found some of our more junior band 6 staff, actually, they don't like saying no, particularly to other members of staff. So actually tell them it's okay. When you've got this on, you can say no. Keeping trolleys and cupboards tidied and well stocked. I've got some examples of that on the next slide. And we also saw some improved team working as well as a result of this, which I'll describe to you again in a moment. So keeping tidy. This, I was shocked when I saw this. How can you possibly find the right medication in there? And again, lots of time being spent sifting through, finding the medication, and also duplicates of medication because you assume it's not there, so you go and get another lot out of the cupboard. But that's what we managed to get to afterwards, and this is what the drug trolleys look like now. Much, much easier to find things. And this is, some of our wards have cupboards in the bays instead of the trolleys. And this ward used their releasing time to care money to buy these red boxes, which they've got the medicines in nicely alphabetically. They've got an inventory on the door there that tells you where each one should be. So again, really easy to find things in this situation. Here are our dream team. Joan Booker ward, this is actually our maternity ward, so it did move out of medicine briefly. So they changed from having named midwives giving medication to their specific named patients to going to a more traditional drug round where actually one person took the trolley around the whole ward. So we thought this was quite forward thinking for midwives actually, because sometimes they think they're not really nurses and they don't do things in a nursey way, but this was actually, you know, sort of being open-minded and doing things a bit more nursey. So they did reduce their drug errors. They had a lot of drugs being given late or not given at all. Obviously a lot of the medication they give is pain relief. So those have reduced through doing this. And they noted this improved team working, which again was at the first time we'd really seen not only a change in process through releasing time to care, but a change in behaviour. So really exciting really to see that coming through. So they increased their direct care time from 33 to 78%, giving them a fantastic 27 minutes more to spend with their patients. So why has it worked this time? As I mentioned, it's been tried a couple of times before within our trust, but this time seems to be actually successful. We're nearly at the end now. We're in our 8th module. We're still going through. So what's been different? So I said, dedicated project manager. It didn't necessarily have to be me, but just somebody who could give their time to the project, actually walking around the wards, meeting with the ward staff one-to-one, chasing them up, chivying them up, keeping the enthusiasm going has been really important. And also I can spend my time developing the plans, collating the data, so we're not asking them to do any of those additional tasks. And one releasing time to care representative actually said to me about the project, she said it does take time, but it's good to focus, and having deadlines makes you do it. So actually giving them the timelines has been really important. We have had high-level executive support from our chief nurse and from our chairman, and without this, again, I think it would have been difficult to implement these trust-wide changes. So having them behind it and actually saying, yep, this is something that we want to do, has been really key. The incentive scheme, I think, has helped. So again, having the financial support, The Dream Team has definitely created an element of competition. So one of the matrons said it's really got her team sort of working together as well. So there's that inter-ward competition, but also between the specialties as well, it's developed that element of competition. And maintaining a high profile, as I said, I think really keeping the energy up, keeping it on the top of the agenda. When I was, before the project started, I was sort of doing a bit of background work and finding out what had happened before. And one of the comments that someone said when I mentioned productive wards, they said, oh yeah, we used to do that, but we don't do it anymore. And that's really not what it's about. So really trying to keep it going and really sort of trying to instill in them that this is something that you keep going. And again, I was at a Band 6 nursing training session, and we were talking about trying to sustain the changes. And one of the nurses piped up and said, well, why wouldn't you keep working like this? Because it's better. So hopefully we've got lots of people with that same attitude. So what have we got to do? I keep saying we're nearly at the end. Patient hygiene module is our final module, and we're currently about halfway through that, so I'm expecting lots of activity follows and feedback on my desk when I get back later in this week. At the end of the module, we're going to repeat the overall direct care time score with another 4-hour follow. So this is going to be the test, really, about whether these changes have been sustained and whether the wards have kept them going, and whether our sort of cumulative effect of the improvements has been made. But I would say that at the moment indications are good. The average, if I take the average increase from each module, we're sitting at 19%. So I'm hopeful that we will achieve our overall 10% increase and hopefully more. The big challenge is sustaining this, sustaining best practice. So I've got a few ideas around sustainability. So I think we need to continue embedding this improvement methodology, the PDSA methodology. So really the message I'm giving now is actually you have the tools to do this. You don't need me there badgering you to do it. And I'm really encouraged when I do get back to my office and there are things on my desk and I've been away for a few days, because I know then that this is carrying on without me going round. So I'm hopeful again that we have gone some way to actually embed this. There's been a suggestion that we form a Releasing Time to Care hit squad. So a small team of some of the more engaged and committed representatives that I've been working with, and there are a few that stand out, that they would be responsible for running a quarterly improvement cycle around issues that get flagged up at our senior leadership meetings. So that's one idea. We definitely need the continued executive support, and I know our chief nurse is very keen on this project. She would have me run it all over again if I could, but unfortunately I've got other things to do and I'm not going to have the time to do that. But I know that she's going to stay behind this, so I think having something that we can do would be really helpful. But obviously we do need to make time for our staff to do this. It is taking them away from their ward duties if we're going to ask them to run these improvement cycles. So we will need a bit of financial support. And again, when I spoke to them and asked them what would they prefer, well, what would they need in the way of financial support, the chief nurse had suggested that perhaps we could give them a little sort of bonus if they were part of this team. But actually what they want is for their time to be backfilled on the ward. So they're quite happy to do this without any financial reward, but knowing that their patients are still being cared for while they're freed up to do that. So just to conclude, going back to our three areas, improved quality and safety. So have we improved quality and safety for our patients at Ashford and St Peter's? I would say yes, and hopefully you've seen, particularly the examples from our medicines and meals module, that this has been clearly demonstrated. Have we developed a culture of improvement within our organisation? Well, again, I think yes. I think we've certainly started it growing, and what's really exciting is it's coming from the bottom up. You know, this is clinical ward-based staff that are actually starting to do this improvement cycle, and hopefully they'll be confident to apply this to future improvements on their wards. And was using a national programme successful? Well, again, yes. I think actually using the Institute Productive Ward Programme has given us the structure and direction that we needed for the project, but we have been able to make it our own within that format. So 3 ticks for all of our trust-wide approach to releasing time to care. Making more time for nurses to do what only nurses do. providing the best care for our patients. Thank you all.
Is it, I mean, it's a great programme, obviously, but what is it that you would say makes it a lean healthcare improvement programme? What is it? What's lean about it? I know it works, which is great.
Yes. What's lean about it?
Yes.
Well, I think because we're making efficiencies with each of the modules, we're looking at nursing processes. So we're leaning the processes. So by using the PDSA cycle, using process mapping, various lean tools, we're able to actually sort of make those processes as efficient and as effective as possible. But the big thing, of course, is driving up the quality of the patient care.
So, so your answer is it's a lean process because you use the lean process to deliver it.
Yeah, we've used tools from the lean toolbox. Right. We've used to deliver the programme.
Okay, great. Thanks.
But you're reducing waste, aren't you? That's what makes it lean.
Yes. Thank you.
During the 8-week cycle that you did each module, how did you actually work with the staff in the actual wards? Did you have a 1-hour workshop every week, or was it a little bit of time, or did you just get them going and then give them the tools and then lead them through it over the 8 weeks?
Yeah, basically we steered away from workshops because that was the second time they ran Productive Ward. That's what they did. They ran them in sort of cohorts and they had workshops, but it was taking staff away from the wards, which is always really difficult to do. So we really tried to run this ward-based. So yeah, I gave them the project plan. I would go and visit them all individually at the beginning of each module, talk them through the plan, and then they've got the tools, they know how to use them, and then basically at least once a week I'll go and visit and see how they're getting on and make sure that they know what they're doing and if they've got any questions. And the quite close monitoring with feedback coming back to me, written feedback coming back halfway through the module and again at the end of the module. So really just monitoring how they're going. And then if they needed any help, then I could provide them with that as we went through.
Okay. And was that so you were training them as they went?
Yeah, essentially, yeah, definitely. And certainly they needed a lot more support for the first 1 or 2 modules. But then once they sort of got off, they can see that the plan follows the same process each time. So I've probably, which again has been a really nice outcome actually, I've been able to kind of give them less and less support as it's gone on, and now it's really trying to say, actually, this is yours now, you can keep going with it, you don't need me there to tell you how to do it.
How did the ward managers take all of this change going on?
On the whole, they've been very supportive. Some of them have allowed staff to come in on days off and then take time back in lieu. Others of them not so supportive, so I've just had to really work with them, and I think as we went through and we started to see improvements, it was easier to get them on board because you can show actually this is working, and you know, if you look at this ward who's next door to you, they've made these improvements and their nurses are saying that, you know, it's more pleasant, their time's easier, so really just kind of spreading the word.
At the end of all this, you want improved patient care. So have you in any way at this moment linked it to patient satisfaction surveys or questionnaires in terms of do you have any outcome data about is it improving patient care and do the patients see it as an improvement?
Yeah, I mean, I've got some sort of patient feedback from individual modules where the staff have asked the patients what they felt. I haven't sort of collated it formally. We're keeping an eye on our friends and family test. And obviously we know what our sort of net promoter score was at the beginning of the project. So again, that's something that we'll be reviewing at the end. So we haven't collected it formally, but hopefully it's a sort of softer outcome that we'll be able to see.
Just another question about the drug round.
Yes.
That sort of whole concept was frowned upon a little while ago.
It was.
Because it goes away from the individual patient care and holistic care, one nurse, one patient,
yep.
and all various nursing things that have gone along. So how did that come about really in terms of...
You're talking about the aprons?
No, the one drug round by one nurse.
Well, again, it was something that the ward came up with themselves, and I think because they were struggling with their named nurses giving it to their patients, they weren't giving them the medication on time, or they weren't giving it at all because they were struggling to do that along with other tasks. So actually allocating one person just to do the drugs and nothing else seemed to get them more focused on it. I think they were just getting distracted, and the drug bit was falling off the end.
I understand all that.
Yeah.
As I say, it was frowned upon in a lot of nursing areas as being going away again from, we've moved from this whole task, drug rounds, pressure area rounds, all of those things into, the nurse focusing on their patient, as it were, and then suddenly that came about. And I take all your points and I agree with them, but I just wondered how they felt in terms of the culture about this is not holistic care for my patient.
I don't know, really. I think, as I say, the whole thing with releasing time to care is it is quite task focused, so it is looking at these individual nursing tasks, but ultimately it is about freeing you up to do the task directly with your patients, so not spending time looking for things or duplicating efforts. So I think within that, the patient is still at the centre of it, but actually sometimes having one person to do the task is more effective for patient care.
I think we should have to leave it there for questions, I'm afraid. But we do have time dedicated this afternoon, so if you hold on to that question,
hold that thought.
Later for you. Thank you very much for that, Sally.
Thank you.